Good morning or good afternoon, and thanks for joining us today for the Holland & Hart Health Law Group's webinar on electronic health records. I'm Kelly McIntosh, and I'm based in our Reno office, and we're going to go through several different topics today, so thanks for joining us in the next hour, and hopefully this will provide some useful information on a lot of things going on in the EHR world. Before we jump into the body of the presentation, going to go through some preliminaries. Today we're going to be discussing what EHR is. Most of you are probably familiar with EHR or have interest in it if you're joining the call. What it is, and also how it's been utilized, and some current trends and things we're seeing in issues arising with EHR use. We're going to discuss meaningful use, the electronic incentive, CMS's incentive payment program, which also has some payment decrease potential that just kicked in this year in 2015, and the current status of meaningful use, and also then some issues that are seeming to arise more frequently with the rollout now through stage 2 of meaningful use to date. We're going to discuss compliance risks and some tips to mitigate risk, and also tips for practical implementation and items to look for as you're utilizing EHR. The written materials are going to be sent out shortly after the program, and they'll include the copy of the presentation slides and also the SAFER guides, which I'll just talk about later, but which are guide documents from healthit.gov that go into a lot of good resource and information for EHR use, and some practical worksheets, checklists, things that may be very useful in your practice setting, whether that's a facility, small private practice, or a host of other settings. Like all of our webinars, this presentation is going to be recorded and available for download on our Health Law blog. If you have any questions, there is a chat feature within the WebEx, so feel free to submit questions that way, or also email me either during or following the program. You can reach me at ksmcintosh@hollandhart.com. And if during the program you experience any technical problems, Luke Kelly would be glad to try and help resolve that, and you can shoot him an email. Again, however, though, if you should drop off or have an issue, we will have the recorded presentation up so you can come back and check it out later. And then the last few disclaimers that are always tagged on. This is going to be a program just offering an overview of legal issues and considerations. You should always review the applicable law, both for the current status and also your local or state and local requirements that may also go beyond just federal requirements. This program does not establish an attorney-client relationship, and this program does not constitute the giving of legal advice. So with that, we will jump into electronic health records. The CMS definition of electronic health records is copied here, and as you can see, quite lengthy, talking about that it's the patient's medical history, maintained over time, kind of goes through the whole course of a patient's treatment. That definition and concept I have brought down a bit because typically you'll hear people talk about EHR and also EMR. Sometimes those terms are used interchangeably. Those are they usually refer to EHR being the electronic health record, and that is primarily that's an aggregate health record. So it may be from multiple sources, multiple instances of care. It's more of a general picture of what a patient's healthcare experience has been. Whereas EMR, electronic medical record, is typically referred to more so as the individual record created by a single organization. So more of a snapshot that then would be included in the bigger EHR to give the more complete picture and experience of a patient's healthcare. So again, while those terms are sometimes used interchangeably, in discussion of electronic records in the healthcare world in general, they do have distinct meanings, and I usually just think of EMR falling within many different EMRs falling within an EHR. And one thing to remember just as a practical matter as well, that whether you're talking about the EMR for an individual record or also the EHR giving the broader picture, remember that the medical record of a patient still may be more than the EMR or the collection of EMRs in an EHR. Things like films, x-rays, often or not, I would say customarily or not always electronic still at this point. There also may be things, different types of monitoring records, sometimes different neuromonitoring or different kinds of specific monitoring are not, still have more of a hard copy product than an electronic capability. So the patient's medical record may have sources that are outside just your electronic data. And that's useful to keep in mind both for patient requests for medical records in the instances of audits, whether that's billing or compliant, kind of across the board of audits. So in any event, just want to make that disclaimer as well. One thing with EHR is, though it's, I would say, still technology that continues to evolve and roll out in different forms, the use of electronic health records is not really it's definitely not brand new, and I would say it's not even necessarily cutting edge. However, with expanded use and new elements of EHR use that may be more cutting edge in their specific new capabilities, there's definitely the opportunity for new benefit, but there are also new challenges. And just a brief background of how we got to where we are to date with the use of EHR. Dating back to 1969, actually, Harvard and Duke's medical schools and related hospitals first started using some electronic components of medical record keeping. So the initial use dates far back. In more recent times, in 2006, which I was kind of shocked putting this together, that's almost been a decade ago now, that was when the Stark exception and an anti-kickback safe harbor were specifically implemented for EMR donation. The provisions for those exceptions and safe harbors were initially set to expire in 2013, but have been extended, so now they're not set to expire until 2021. But even looking at that, the first regulatory acknowledgement and allowance for certain things to be permitted, given the new electronic world in which we live, dates back now to 2006. The HITECH Act, which came out in 2009, rolled out a lot of new components that deal with electronic health records and electronic use of data in the healthcare world. It modified a lot of supplemented and modified things under HIPAA, and it also is where the Meaningful Use Program was first, that was the act through which it was enacted. So the regulations came out separately and are still actually coming out, but the HITECH Act in 2009 was where meaningful use was first adopted. Speaking to meaningful use, the first incentive payment under meaningful use happened in 2011, and the first penalty or payment reduction, those went into effect just this year in 2015. So meaningful use now has the kind of carrot and stick components both in effect, but has also been rolling out for several years as well. And finally, one thing that I think has driven the use of EHR across the healthcare industry is the increase of clinically integrated networks and ACOs, which has been a huge increase across most areas of the healthcare industry, especially since the enactment of the Affordable Care Act. And one of the key focuses, both ACOs and clinically integrated networks, encourage the use of EHR significantly, and it's typically a very central component of being a part of an ACO or clinically integrated network, with the thought being that EHR and EHR use allow for providers to more easily and efficiently share information and hopefully then achieve efficiencies in patient care relating from having data available and easily accessed. A couple things that still are questions that are issues that I see developing, and where I think the new issues are arising because they are fairly new products and things that are still continuing to roll out. The one being patient portals and personal health records. The use of patient portals was formally required for attesting in meaningful use stage 2. And this is the ability for patients to more easily access their healthcare information. They can go into patient records that are their EHR that's maintained electronically, have access to that, be able to download that information, communicate preferences back to their provider through this electronic system, receive reminders for care. And in meaningful use, both, which we'll discuss the different players in meaningful use in a few minutes, but both eligible professionals and eligible hospitals have requirements under meaningful use stage 2 for attesting to the use of patient portals. So this is something that now in most or I would say a large amount of the ways that patients will be accessing the healthcare system, the providers that they're going to see and with which they'll be dealing are going to be more and more likely to have patient portals. And I think patients are going to start to expect and demand both that information and be very sensitive to making sure that those things are easily accessible, have good patient experience and interface. The other thing, to date, I've seen a lot of a benefit, I think, from the patient portal and personal health care records increase is patients taking more ownership over their health care to some extent now that they have information more readily available at their fingers. They can sync up information and reminders with their other technology and really just keep their healthcare as part of their normally scheduled events. So it's something that, there are different formats. I would imagine that as time goes on, the patient portal experience will probably become more similar just because across then platforms, patients are going to want to know what to expect when they log in and things like that. But it's definitely something that has been rolling out and continues to roll out, and I think has some exciting potential for healthcare. Another thing that's not new, but also still has a lot of ongoing and developing issues is telemedicine, or the use of different types of electronic, mobile, remote technology to allow providers and patients to connect. And one thing that's interesting on some fronts, I've found, and this is usually more specific to state law considerations, but state laws on provider licensure or what it means to establish a physician-patient relationship are developing rapidly, or as rapidly as possible, and not always, definitely not the same in all states, but they're, I think, trying to attempt to address new technologies that are popping up, whether that be video conferencing on cell phones remotely, or taking a picture and being able to text for information from a provider. Some of the things that are new issues that I think state regulators are just trying to address as they come up, and as I mentioned, are not not always quite in time the same as when the technology is rolling out, but those are continuing to develop. So I would encourage you, if you're in a practice setting where the remote type of technologies or telemedicine is something that you're using or your patients are requesting, definitely with each new technology you may hear in the news or receive an email about a new product, before implementing it in your practice, just keep in mind that there are state law items, or even if a product is HIPAA compliant or some of the things that may be touted on the product side and have federal implications, just make sure that it's not going to put your providers in hot water or your practice in jeopardy under your state laws as well. With the use of EHR, there's definitely a lot of opportunities for good results, for improved healthcare experiences for providers and patients. The kind of pro side of the column of use of EHR rolling out, this is actually a list that these are the items that CMS has included on their information about EHR as to why they see EHR as something that can improve patient care, helping reduce incidence of medical error, making health information available, which should reduce duplication, delays, and allow patients to be more well informed, and also improving accuracy and clarity to hopefully reduce medical error. Also, some of the other pros that I see and are often talked about and discussed are increased ability for continuity of care, sort of along the line of what I was mentioning in clinically integrated networks and ACOs, that with the use of EHR, now medical records and health data can more easily follow a patient rather than being recreated at each new door that the patient walks through for a different provider. Care settings are able to share that information to, among one another to hopefully have results like reduced readmissions, better disease management or co-management of certain conditions, and also better placement to determine that the patient's at the right level of care. It also helps support things like evidence-based decision-making. It, again, allows that data to be readily available so that clinical, the evidence is clearly recorded and accessible to have the decision-making made in whatever step of care that's at. Similarly, evidence-based reimbursement, it's with clearer documentation, you have a better opportunity to have coding correctly the first time and not have coding issues. It definitely allows for computer-assisted processes in the coding and billing process, and also then is helpful in the case of an audit or follow-up by a payer source to help demonstrate that the care was provided, the level of service was there, the support for the billed charge is reflected in the electronic record. And finally, what I've mentioned in part with the patient portals and personal health records, patient engagement, I think, is a great result and byproduct of rolling this out. I don't know that it was necessarily one of the most touted up front as a possible opportunity, but I think it's been a great result in that patients now feel and can see easily in an electronic form what their healthcare experience has included, know when their next follow-up is, and just be able to track that more easily. So that was the good and some of the upshoots of EHR. But as I mentioned, with new technology and new frontiers comes also potentials for liability and some potential downsides or actual downsides that are playing out that are just due to this changing landscape. This is information from a malpractice carrier, and I thought it was pretty informative interesting regarding just in 1 year's worth of claims, 147 cases had EHR involvement and as a contributing factor. That included $61 million in direct payments and legal expenses in this 1 year period. And the leading causes that EHR played into as a contributing factor in these cases were either incorrect information going into the EHR, having some issue in converting health records either from a paper format to an electronic format, or conversion between systems and having data issues in that respect. System failures where information wasn't being routed in the right way, or there was an inability to access the data. And I would imagine that this item, I think this information was released, I believe, last year, but I think was gathered from a year, 2 or 3 years back, like 2012 or 13. And I would guess that this last item is probably higher if you were to look at a snapshot of last year or in the years probably going forward. Pre-populating and copying and pasting. I'll discuss this a bit more later, but that was 10% of the claims there and contributed as a factor to malpractice risk. Another survey, also, this was done by the American Health Lawyers Association and Association of Risk Managers, and talked about when participants and respondents in the survey had dealt with an EHR-related serious safety event. And more than half had dealt with at least one event that included EHR in the 5 years preceding the survey. And more than 10%, or right around 10%, reported more than 20 events. So that, is also a pretty good snapshot to indicate that EHR issues, while they may have also prevented issues that otherwise would have arisen, they bring with them their own concerns and possible safety events. The OIG has issued two specific, well, it's actually issued in many different forms, its thoughts and some concerns or issues of which to be aware regarding the use of EHR. Two that were very informative and came out pretty close in time together at the end of 2013 and beginning of 2014 were discussing that EHR technology in the hospital setting, and also the rollout of EHR in connection with CMS and their contractors and program integrity practices. There are links here to both of those reports, and they have a lot of helpful information. I won't go through in line by line what their identified risk areas, because usually they're pretty much covered throughout the rest of this, but not only do they identify areas of risk, they also go into recommended action items. And I always find the OIG information to be quite informative and instructive, because it seems to give a good roadmap of what the regulators are looking at, what the OIG and potentially DOJ, or what the enforcement arms of these authorities are going to be considering, either in enforcement or on the regulatory side to promulgate new regulations going forward. So I would direct you to definitely check out those two reports. Some of the things, and this is in general, but some of the risks I'll go into now are identified in those reports. Specifically, some of the areas for liability risks and potential pitfalls of EHR use include security risks. This is definitely a thought that goes along with HIPAA. The focus of my discussion is not to get into the details of the HIPAA security requirements. We actually have another couple of recorded webinars if you're interested in those requirements that detail what HIPAA calls for more specifically. But the security risks tied to HIPAA, and one thing that makes EHR use such a large security risk, and why there are so many news-making stories about data being lost or stolen, is that large amount of data is now accessible via one connection, one point of contact. If someone is a bad actor or is trying to improperly take information, rather than having to raid a file cabinet, it can be as easy now as stealing a laptop or downloading information onto a portable media device, or printing things out and taking the hard copies. So there's a lot more risk just in the portability of the information, which is, a benefit, but this is the flip side of that benefit. And also, as is frequently in headlines, the security risks and the result to covered entities for having a breach based on either something that was more inadvertent, like a lost laptop, or more of a bad act where there was a intentional event to take and access information. Both state attorney generals and the Office of Civil Rights are involved in investigating and then oftentimes reaching extremely large settlements with covered entities based on the size of the breach involved or the effect that it had on, based on how the information was used. Some of the other items that are more on the con side of, or the downside of the EHR, one just goes to the thought that this is a whole new system and it's a very technologically driven system. So implementation costs can be not only an upfront cost that's significant, but ongoing as well. Investing in the initial infrastructure, training, making sure that systems for backup and updates are rolled out, maintenance is taken care of. The fact that most of this technology is through computers or other computer-like devices, tablets, sometimes even smartphones, etc. But by the nature of devices of some of those types, you can have things that just go along with them, like downtime, viruses, crashes, things that you wouldn't have necessarily experienced in the same way when it was a human jotting down a note on a piece of paper. And then also, now that you're putting those humans into this interaction system, there's also just a different type and level of potential for user error, where before perhaps there was illegibility issues or an incorrect word written down or then dictated or transcribed. Now you have different issues where users may not be familiar with the system. They may inadvertently check the wrong box, click the wrong menu. So just different types of user error, but still putting that human component in there just allows different areas for risk. So now just going to discuss for a few minutes the meaningful use, where we're at in the meaningful use process, and some of the issues that I'm seeing discussed fairly frequently regarding meaningful use. And I would imagine largely most of you are probably familiar with the Meaningful Use Program in general. As I mentioned earlier, it was enacted as part of the HITECH Act in 2009. The Stage 1 final rule came out in July of 2010. Stage 2 was issued in September 2012. And actually, very timely, Stage 3, the proposed rule for Stage 3 was just issued last Friday. It is about 300 or so pages of light reading, should you find yourself looking for something to absorb and go through. But it just rolls out of the proposed rule. A final rule will be forthcoming about the next and final stage of meaningful use. And it calls for compliance with the components in Stage 3 by 2018. Some of the things, and some of these may, as the proposed rule receives comments and has discussion and reduces down to the final rule, may change, but the stage 3 requirements largely just build upon stage 1 and 2, and without going into great detail and in stage 1 and 2, for those that may not be as familiar, there are different areas that to which providers must attest, showing that they've implemented certified healthcare technology in their practice in different fashions. So the stage 3 requirements kind of build on that and have new, either enhanced thresholds in certain components, or different measures. Things like e-prescribing have increased thresholds. There are new measures talking about clinical decision support. The computerized physician order entry tools has also new orders that's usually referred to as the CPOE. And there's one thing that was mentioned that came up in that, which I thought was interesting. The use of scribes now is suggested to be included in that, which means personnel that would just have a medical assistant credential. So kind of expanding also the staff and personnel that may be able to be part of the meaningful use, the processes that go into being able to attest that a practice is or facility is meaningfully using EHR. Also, there's additional heightened patient access to information requirements. There are actually now as well, not just access, but patient engagement measures as well, so that patients actually have received their records or have received a message, have accessed their records. And this just, not only has the process is available, but now it's actively being implemented. And finally, kind of the third area of the proposed stage 3 is getting to things like interoperability between different systems and things like the health information exchanges and public health and clinical data registry reporting. So, and within those there are several different measures, but again, those are some of the things that aren't necessarily groundbreaking. I don't think there's anything that I've seen discussion that was really a shock to many folks, but more so these build upon some of the previous steps for implementing the use of EHR, and then now have certain heightened measures for providers to get to this third stage of meaningful use. And under meaningful use, again, this is kind of general and probably something that most of with which you're familiar, is that meaningful use has one side that is incentive payments, and that's under which hospitals and eligible professionals are able to receive incentive payments for using certified EHR technology. And there are different programs under the Medicare and Medicaid systems. And then on the flip side of that, there are payment adjustments that just started this year, and those are where there has not been attestation showing meaningful use of certified EHR technology. Now there's actually a decrease in payment implemented for either eligible hospitals or eligible professionals who have not met the attestation. And I use the term eligible hospitals and eligible professionals because that doesn't necessarily include every hospital and every professional. So to the extent you're not familiar, you're not in a setting where meaningful use has been something that you've been attesting to, and you don't know if you should be, or you're going to have now payment adjustment. Later in the program, I have links to the meaningful use CMS website, and I would just suggest you go there and confirm if you're in one of the categories that is an eligible hospital or eligible professional. And as I mentioned, that this ties to the term certified EHR technology, and attesting that the practice or the hospital or professional is meaningfully using certified EHR technology. The criteria for that changed from what was initially set forth in 2011 to 2014. So again, that's another area where I would expect, or at least think there may be a continuing adjustment to that criteria, and something that, especially if you serve in a role where you're a coordinator for EHR meaningful use attestations, or ensuring that your practice going into each next year is ready to get the data and take the activities necessary to make those attestations. Just be mindful that the criteria may continue to evolve, and you want to make sure that you're using the current effective criteria. And as I mentioned a few times, the process through which you either are able to qualify for incentive payments, or by which you show that you will not be subject to a payment adjustment, are through making attestations to CMS, and that process is done through the CMS website, an online submission, and the reporting periods of that are based on calendar years. The reporting period has been extended in years past. I don't know if the system continues to roll out and people continue to be more familiar with making the attestations. Those deadlines, I would imagine, will begin to be more firm each year. Some of the issues that then I've seen now that meaningful use has been implemented through stage 2 to date, a big one that I think is going to continue to increase are meaningful use audits, and the process to either before payment is made, prepay audits, or post-pay audits, to make sure that eligible professional or eligible hospital that's receiving incentive funds or has attested that they should not have a payment reduction are actually appropriately using the EHR in the way that they've attested. And the next thought along that is, if you're subject to an audit, there's also a process for appealing the audit results. And some of these things are only going to increase now that many more providers are have now attested for meaningful use purposes. And the biggest suggestion I would have in general about audits is make sure that you take any piece of paper that you receive or contacts you receive regarding your attestations and your meaningful use seriously. Don't just kind of gloss over it, because if you don't make a response when you receive information about an audit, if you didn't respond, then you have nothing to appeal. So again, it's something where you just, I think, want to make sure that you're staying aware of the changing landscape in how audits are being conducted. There's both audits are triggered either through just a random process, or also using risk profiles where there's suspicious data or anomalies, and even could be successive audits if there continues to be the kind of anomalies or different data that wouldn't be expected received. So so it's a big suggestion is just to make sure keep your eye out for anything that talks about your meaningful use attestations, and if it is an audit, make sure you're responsive and timely, and as well, just to always maintain documentation that backs up your attestation. There, at least 6 years post attestation would be suggested, if not more, And, you know, definitely try and save both electronic and paper documentation. Often snapshots of screens, if you aren't able to print certain screens or can just maintain an electronic file, do screenshots, screen grabs of what's being submitted or the data on which you're relying to make your submissions. And also on the link that's referenced later about the CMS link to the Meaningful Use, their page that has all the information on the program. On there are some audit resources that also I would suggest if you bookmark or just keep handy, that talk about what the kind of what types of documentation you'd want to have in the case of an audit, sample audit letters, so you could also familiarize yourself with what a letter may look like, and just an overview and fact sheet of the audit process. Also, and there's been at least several headline-making stories on this front as well, where providers have improperly received meaningful use payments, and after the fact determined that those were the factors necessary to claim that payment actually had not been implemented, or the attestation somehow had not been made correctly or appropriately, and that triggers then repayment obligations. I've seen even, I think, up to 30+ million in repayment obligations for meaningful use. So once you've made the attestation, definitely don't stick your head in the sand. If you receive information after the fact that would indicate that some portion of either your measure or your attestation were not correct, then look into either what that means. If you have other information that could have been used for the attestation, whether that's submitting then additional information to CMS after the fact, or taking steps to make repayment of any amounts that were improperly received. Or if you haven't yet made the attestation, holding immediately until you determine if it can appropriately be made. And then another thing that I've seen come up quite a bit are disputes about who actually is entitled to meaningful use payments. Again, the categories of eligible persons to receive meaningful use incentive payments are either eligible hospitals or eligible professionals. So, for instance, group practice settings may have several eligible professionals, or private practice settings, but the private practice itself is not an entity or a person, a legal person that would be entitled to meaningful use payments. That said, often, especially in private practice type settings, it would be the practice that is investing the resources and establishing the systems and framework for meeting meaningful use, and so often it would be the kind of the practice-based setting that may be putting out the expenditures and really bearing some of the risk and cost to get meaningful use up and running to then result in incentive payments, but those payments are still made to the individual professionals that are making their attestations and demonstrating that they meaningfully used certified EHR technology. So just whichever side you may be on of either the system or practice setting that's implementing meaningful use systems, or the individual side, in thinking about your contracts between one another or obligations for making attestations. Those are items I would suggest you think about on the front side, rather than when the check comes in and then all of a sudden there's nothing necessarily documented and differing opinions on whose money that really is. So now moving into, for the last portion of the webinar, EHR help or EHR tips and items to either give you resources to assist in your practice, and also just compliance bullets to maybe give you a framework of issues to keep aware and on your forefront to make sure that your practice or your system and setting is correctly and efficiently and appropriately using EHR. As I mentioned earlier, and this is going to be something that's included with the materials that go out for the program, the SAFER guidelines are a system that has been, or a series of guidelines and different worksheets and checklists. The SAFER stands for the Safety Assurance Factors for EHR Resilience, and they're put out through the healthit.gov site. They're organized, there's 9 different guides on different topics into 3 broad categories, and those help you across your type of healthcare organization to address EHR safety in many different areas. For most organizations, you want to start with the foundational guidelines, and then the other, which I'll mention in a moment, the infrastructure guidelines or clinical process guidelines are sort of kind of the next step down in the tree, and to the extent they're applicable or of interest to your practice setting and organization, also may have helpful resources. Here's also where not only the guides that I'll include, but additional resources are available at the healthit.gov site. And from time to time, they'll put on specific webinars on topics as well. It's a site I would definitely suggest also bookmarking and checking with some frequency just to see what new information may be available and helpful to your organization. As I mentioned, the 3 categories of where they have guidelines are the foundational guidelines that are broken into high priority practices and organizational responsibilities, infrastructure guidelines that are system configuration, system interfaces, and contingency planning. Contingency planning meaning when your EHR system may be down or not accessible. And then clinical process guides, and that's discussing patient identification, computerized provider order entry with decision support, the CPOE, as it's typically referred to, test results reporting and follow-up, and clinician communication. Within the SAFER guides, there are checklists with interactive status options and worksheets. So the guides are things where you can go in and select the box or go through the checklist and select the bullet that you've hit or have implemented in part certain configurations or certain processes that are suggested and recommended. And then, so one, it goes through the checklist of items to implement and suggested practices, but then each of those also has a backup, or I think most of them at least have backup worksheets that also then will pop up. And the worksheets give some additional very helpful information. It can talk with things like rationales for practice or risk assessment, suggested sources of input. The worksheets contain examples for potentially useful practices and scenarios. And then they also have references if you're looking for the authority for some of the components or additional information on something that may be very specific to your organization. So again, I think these are something that I would suggest if you can keep them locally, keep the guides up to be able to pull up and use the interactive PDFs, or definitely have the website handy to be able to go in and hopefully these will be helpful to your organization. In EHR use generally, I'd like to definitely highlight what many of you probably have realized as you've begun to have EHR more and more frequently used in your organizations. Though this is a technological advancement, this is not just an IT project. Putting an EHR system in and implementing EHR is something that is really a team-based project, and needs elements of compliance, IT, patient quality, and quality and patient safety HR component based on your organization type and size, and then also input and overview from legal and risk management. Things that I would suggest also looking at or keeping in mind as you're rolling out an EHR system. You'll want to note, for instance, on access level or what you're trying to accomplish with the EHR, that there's the proper licensure and scope of practice for the role and the activity in which the individual is engaging. So as an example, under some of the meaningful use criteria and the measures that go to those items, you have to have certain personnel use EHR and make record patient data using the EHR. That doesn't necessarily include all personnel. There are certain requirements, as I mentioned, just in the proposed rule. Now scribes have been included in some of the items, but there are still certain thresholds for either the credentials, training, licensure, et cetera, of who is using that. So being aware of those requirements, and then also to the extent you can, either working with your vendor or setting up your system so that hopefully your EHR system is intuitive and can help make sure that users that have access to certain information or certain processes have those right licensure and scope of practice levels. Sort of connected with that, also looking toward accessing EHR system as a role-based access concept, and this could be both internally and externally. So internally, if staff or different types of staff have access to certain information versus physician, provider, direct provider, patient care level access, and also externally for billing companies, auditors, depending on who's accessing and the role in which they serve, what they can access and how they can access. If it's something that's able to actually edit information, just view information, things like that. Having specific policies and procedures in place sort of across that, the prior screen's threshold of compliance, HR, whatever the piece of your organization may be that's weighing in, but policies and procedures that talk about how the EHR is being implemented in your organization and how individuals that are utilizing the EHR should be doing so. And then with those policies and procedures, definitely implementing education and training to support that the members of your organization understand the policies and procedures and the EHR system that they're using. Use of efficiency tools, I would say, to me, is one of the biggest things that should be an area of just at least awareness, if not necessarily concern, but something to continue to be aware. And efficiency tools include things like copy and paste. The copy and paste type function has been mentioned in the OIG work plan for a few years now. The thought that a provider can just copy and paste a patient experience into a new form, then adjust a few things, and to some extent there could be some benefit to not recreating a whole description, but not making it just a copy and paste that doesn't accurately reflect what would happen in the specific patient encounter. Along that line, clone documentation, which is kind of copy and paste that's just more the extreme use of cloning and using the same data, that's something that Medicare administrative contractors, the MACs like Palmetto, Noridian, NGA, they've, I believe most, if not all MACs now have posted comments and guidance and areas of which to be aware regarding clone data, and that's something that they're looking to and taking action to make sure that there aren't fraudulent claims being submitted with cloned data. CMS specifically has indicated that they're sensitive to and will be reviewing where there's multiple E&M services with the same physician and same beneficiary to identify, if there's been potentially improper EHR use where there hasn't been, it's just a copy and paste without any adjustment to reflect what actually happened in that care. Drop-down menus as well are something that can help with efficiency, but they can promote a problem throughout an EHR record if the wrong drop-down is selected at any stage really in the EHR documentation process. Often those are then interconnected to what would be successive screens or successive prompts. So if something is inadvertently, erroneously selected, especially early in a record, it could have the effect of not prompting or carrying incorrect information then throughout the EHR. So just something else to be aware of. And finally, templates. Again, CMS has actually specifically indicated that the templates are not prohibited, and there can be some benefit to having templates where certain frameworks of a record are already set forth, but that also can help or could possibly promote continued problems, especially where it's a template that's either a no or a negative type template, where then it may preclude or not prompt for other items because it was a negative result, so it just kind of carries that no or not applicable concept then throughout the record. And another thing, definitely to the extent you can in your organization, auditing your EHR use for how timely information's included, making sure that there's authorship, authorization, authenticity type components, the EHR, auditing for things like the efficiency tool use, just keeping on top of what is going on in your EHR system is going to be very useful. And if you can do that internally, it's going to help offset some risk you may have in audit externally from either a government program, an administrator contractor, a private payer, whatever the case may be. And we're almost out of time, just another minute or two. As I mentioned, there was a lot to cover here, so I was trying to touch on some of the high points, but also wanted to give you some additional resources. The OIG's fraud and abuse website, I think it's a good reference for most across the healthcare most of the time, and it ties into some of the EHR, especially in terms of overpayments. That's where especially advisory bulletins and fraud alerts are put out on things that have occurred and that then you may want to check in your organization or give you an update on what's on the radar of the OIG. The meaningful use, the CMS EHR Incentive Program website. This is a link to the primary page on that that'll go into both if you're trying to actually go in and make your attestations, if you're looking for audit information, that's a great resource. The CMS electronic health record site, also very helpful. That'll give you some more of the CMS and Medicare side on electronic health records. As I mentioned, healthit.gov, the site generally has a lot of information on the health IT information. This is also where you'll find the SAFER guides and the SAFER information. And one thing to be aware, there's a lot of material available on the internet, especially in the context of EHR technology, things that are changing rapidly, both in capabilities, the legal framework. Just be careful, especially as to dates. There's also just a lot of incorrect and bad information out there, but looking at something that's from 2008 or 9 may have very little relevance to how you actually need to be implementing EHR today in your organization. Some additional resources from Holland and Hart. Our healthcare update and healthcare blog has a lot of information. As I mentioned, that's where our past webinars are recorded, and especially things like HIPAA and repayment programs are on there and may tie into some of the elements you're going to encounter in your EHR implementation. We have some future webinars on antitrust, FDA and medical devices, and pharmacy, prescription, and controlled substances. I hope you can join us for those. And again, please feel free to reach out with any questions, and hope we can connect in the future. Thanks much for joining us, and have a great day.